Good morning and welcome to day 2 of the hashtag Co-Create Design Festival for 2021. Our focus today is going to be in the space of health. And my word, what isn't there to talk about in the space of health? We are, more than 520 days into some form of lockdown since we were taken into it by the administration in March of last year. Alert level 2 seems nicer than alert level 3, but alert level 1, in fact no alert level whatsoever, is ultimately the desirable. There are many lessons for South Africa to learn from certainly the last 18 months or so. There are opportunities that I think we can develop and grow from and make sure that we improve the health system in South Africa that is generally, well, not even and fair, nor just, some would argue. We've got a wonderful program of speakers for you over the next 2 hours. We hope you're going to be joining in the conversation by using the chat function to pose any questions to these speakers. And obviously, we will direct those questions to the speakers as the morning unfolds. We do have a small and intimate group here at the Biscuit Mill who also are most welcome, of course, to ask your questions of the speakers. My name is Melane. It's my joy and pleasure to be your master of ceremonies for this morning. The speakers we have lined up for you. Russell Rensburg is a director of the Rural Health Advocacy Project. He'll be talking to what don't we know, which is a very interesting question to answer, isn't it? How do you not know what you don't know? But how we, most importantly as South Africans, can contribute to the solutions that exist there. We'll go to the Netherlands and speak to Dr. Simona Rocchi, who's a Senior Research Director of Design for Sustainability and Innovation at Philips Experience Design, and looking at how we can build inclusive healthcare in a complex South Africa, how technology and other systems around design can help us achieve that. We'll hear from Dr. Mulder, who's with the South African Medical Research Council, on how investment in research and development will help build our homegrown resilience. And my word, has that not been tested today. And then, to start us off though, not one, but 2 speakers this morning. Gaurang Tanna is the head of policy coordination and integrated planning at the National Department of Health. He's worked on strategic health information systems projects, led to the development and implementation of various planning frameworks for the health sector. He'll be joined by Dr. Zameer Brey, who served as a process analyst for the Western Cape Department of Health, as an internal consultant of the Deanery of the Faculty of Health Sciences at the University of Cape Town, and has been involved with consulting to the National Departments of Health and Higher Education. Both gentlemen will be speaking to what we've learned during COVID-19 and how we can build on those lessons to build a more equitable healthcare system for South Africa. It's lovely to have you both, Gaurang and Dr. Brey. Gaurang, I'll hand over to you. Good morning.
Good morning, Africa, and again, thanks for inviting us. I'm going to start by just broadly talking about the health system, then the COVID response, and Zameer then will come in with a couple of points on the agility and the responsiveness, as well as some of the innovations that we've had to lead the implementation of certain interventions. And perhaps just some first principles. We've known in the health system that impact can only really be realized unless we have a health system with high coverage and one that provides good quality care. The universal health coverage goal, which we as a country, and I think the world, has subscribed to and aspire towards locally through the implementation of NHI, is not just about coverage, but also about quality of that coverage with financial protection. And we know coverage is largely going to be overcome by ensuring population has access to care. Quality is actually about, the care that's provided by healthcare professionals is safe, doesn't do harm, is in the best interest of the patient, and that there is continuity of care when our population is navigating through the healthcare system and not lost in the system. Often our program is confused and interpreted by many as exclusively a health financing reform, and it's not really that. We agree that there's a need for financing healthcare differently in South Africa, but that is not sufficient and needs to be complemented by reforming and strengthening other building blocks of the system, which we think are equally, perhaps even more important. So improving leadership governance to ensure that the system is ethical, transparent, person-centered, respects the view of the people it serves, it's better managed, has adequate checks and balances, and accountable human resources for health, which really accounts for 2/3 of the health expenditure in public sector and probably even higher in the private sector. Using technology to improve efficiency. I'm listing 3 of the critical building blocks, but I think there are 3 others, and I think will be critical to ensure that we see the importance of a system as a whole that needs to be strengthened and not just part of it. We know in South Africa they're challenged in both public and private systems, but the systems are challenged very differently. Um, so very critical that we have the right interventions for the different systems to ultimately ensure that to ultimately ensure that the 2 systems are playing a very complementary role because both must be leveraged as we aspire towards this one health system in South Africa. I mean, on the one hand, the COVID-19 pandemic has exposed these fault lines in our health system and society as a whole, but it's also made the need for reforms more urgent. But it also has shown our collective ability and capability to do things differently, and really shown some of the benefits early on. What the potential outcome could look like if we just operate collaboratively. I mean, with COVID-19 situation worsened locally and globally, planning didn't keep up. In response, the pandemic really induced a lot of pressure. Policymakers became very quickly overwhelmed, became reactive, particularly also because this was very much an uncharted territory for local and global policymakers. I mean, others contended that protecting the economy was more important than tackling the pandemic, but it became very clear very quickly that they were actually not mutually exclusive. It's very complex because they also intertwined. I mean, having said that, we know it's a very tight rope to walk between saving lives and saving livelihoods, especially with a very diverse and a heterogeneous population with varying contexts we have in South Africa. There is an inherent danger of widespread infections and by implication, multiple burdens on the healthcare system. I think providing quality care and making things safe for patients is challenging, even more challenging in a pandemic from multiple fronts. The health system was overwhelmed due to the virus. Available resources had to be reprioritized. There was implicit and explicit rationing, both locally and globally, due to this added burden. Available resources were deployed away from usual care, and there was a surge in new cases. Many patients chose to stay away from routine care due to the fear of the virus and restrictions, which in itself had fairly negative consequences, for the health outcomes. I mean, SAMRC has just released a couple of months ago, showing that life expectancy in South Africa has declined by 3.5 years, almost wiping out 7 or 8 or 9 years of gain we've had in the health system. So no doubt there's been serious ramifications and the harm the pandemic has done. WHO in 2007 already has said healthcare is everybody's business. The pandemic has really shown why it really is. Healthcare and systems are really now high on the agenda across sectors, across societies. Everyone recognizes that no one is safe until we all are. Everyone talks about the importance of health. So if anything, it has a potential to unite the nation and health system it serves. The importance of giving agency to people to take charge of his own health. Everyone talks about hand hygiene. I mean, as an example, a non-pharmaceutical intervention. There was great agility in the response across the board from policymakers to religious leaders, business. We've really all learned new ways of doing things. Change has been seriously painful, but one that's been welcomed for the upside that people want to. It really has made the need for health system reforms even more urgent and catalyzed their realization using a patient-centric approach. And I want to hand over to Zameer to just walk us through some of the experiences in South Africa. Zameer, over to you.
Sure. Thanks, Gaurang, and thanks, MC and colleagues, for the opportunity. Gaurang was talking a little bit about how kind of health and well-being became everybody's business in a very short period of time. And if we just reflect as kind of, folks working in the health system, it's probably the first time ever in our careers where 90% of coffee discussions or the odd Brey that actually happens, we're talking about variants, and we're talking about the family meeting, of which 90% since the president's come into his position have actually been about the issue of health and well-being, whether COVID, whether GBV, or some other matter. And so I think that health has occupied this unprecedented level of attention and scrutiny, and mostly Africa, that's been exceptional. I think there has been a little bit of a downside, which we probably don't want to go into right now around, suddenly we've found many WhatsApp professors and Facebook specialists. But I think largely the outcome of that kind of dialogue has meant that everybody's interested, not only in COVID, in many other diseases, and that actually we can see very tangible evidence of that kind of dialogue and engagement from the public. And I think comes back to the issue of this response was not about what government did or what leaders did. The response was about what individuals, communities actually did and took agency. So at the systems level, I think some of the innovation that was really exciting and encouraging to see is that it shifted our mental model of healthcare delivery quite substantially. So, traditionally we deliver healthcare in hospitals and clinics. But during the pandemic, we had to push beyond those kind of imaginary boundaries and say to ourselves, where do people actually meet? Where is convenient for them? So whether that's in malls or shops, community halls, places, religious places of worship, and even grant queues, Africa, some really interesting work going on both for testing and now for vaccination, is rather than expect people to come where you are as the health system, is go to where they are. And we do hope that some of these technologies that we list over here will see themselves being translated to routine service delivery for other diseases. We know that technology during this time was leveraged appropriately and put the patient in the center of these solutions. So often we find, the technology being applied, but the problem statement's not clear. And the problem statement seldom actually involves the patient themselves or the recipient of care. Whereas during this COVID period, we saw, a number of solutions proliferate, including the use of a mobile phone for giving information about COVID, for screening yourself for COVID, but also beyond just the health sector. Incredible to see 10 million South Africans screened using technology for their eligibility on a social grant. That's a game-changing story, not just for South Africa, but for the continent. And we also saw how care was being taken closer to patients through the multiple models of telehealth, which enabled patients to be protected at the time and practitioners also, but connected the need with the demand. Two or three other things that really strikes us as threads that we hope build out this tapestry of a new health service kind of design is the whole of society approach. As I think through who played a role in the COVID response, it's hard to think about who didn't play a role. whether it was political leaderships making decisions in a responsive, timely, agile way, whether it was religious or community leaders standing up to empower their communities with information, support them during this difficult period, business, playing their part to limit the spread, and individuals, empowering themselves and their families and communities. We probably did see this concept of a whole of society approach come together like never before. In terms of partnerships again, and Gaurang touched on it, we saw how the public and private sector started to pool data, and that was super critical in the time of a pandemic that spread so fast, because it allowed us to see trends and hotspots in a way that we've not seen before. That kind of initial sharing of data then extended to sharing of testing platforms, including with academia, and Shally may touch on that a bit later. But we saw, for example, the repurposing of existing infrastructure, testing infrastructure to support COVID in universities across the country. And now we see the public and private sector sharing platforms to vaccinate the public at significant scale. We see a large part of the private sector vaccination capacity actually servicing the uninsured individuals, which we think holds a lot of promise for a universal healthcare model going forward. And I think that, where we should be taking the discussion now is how do we hold on to and harness these innovations beyond COVID? And I think there are a couple of very tangible ways that can be done. We'll just put a couple of questions on the table, but we know that putting the data out there really helps. So, Africa, a simple example of who would have thought that, a COVID dashboard would be, or sharing data about COVID data would be so interesting. That dashboard's got millions of hits. And it's not just a small group of epidemiologists and public health specialists sitting in a dark office trying to figure out what's going on. It's everybody looking at the data. And surely we could do this with other diseases that spread rapidly, like TB, like the flu, etc. Then, at the political level, we probably have never seen this level of engagement and commitment across a multiplicity of government departments, whether it's the Department of Transport, Department of Sports, obviously health, finance, etc., was really an all hands on deck approach. And should we have this for the leading cause of death in South Africa as a permanent feature? So whether it is TB or HIV, should we not have all the political leadership focused on how to bend the curve on, leading causes of death over time? So, and certainly some of the mobile technologies we know already lend themselves to being used for other diseases. And I think that we shouldn't, waste too much time in seeking out these models. And I guess one other thing is also, I should have mentioned in terms of partnerships, there's a host of novel partnerships that have shown us the potential of what a new healthcare system or a revised, updated 2.0 healthcare system looks like. And if we have a good look at what the need and the problem statement is, gives us a good sense of what where this could go. So take, for example, Africa. Uber had made a donation to help with medication deliveries during the lockdowns. That pilot project turned into a big project. In fact, just close to where you're sitting right now, Africa, right there in Cape Town, has delivered over 1 million packages of medication to patients in need, the most vulnerable patients, by linking, Uber capacity with community healthcare workers who are the star of this program, but have been able to deliver, more than 1 million packages, and have given the government in the Western Cape the opportunity to scale that project up, 10 or 20-fold. and similarly are using that kind of spare capacity in the transport sector for now thinking through how do we make it easier for people to access vaccinations wherever they may be, because we know that this is a barrier. So I think just a couple of examples to put out there, but happy to engage in a bit of discussion, take some questions. Over.
Thank you very much to both Gaurang Tanna, the Head of Policy Coordination and Integrated Planning at the National Department of Health, as well as Dr. Brey, who's employed at the Bill and Melinda Gates Foundation. And I suppose one quick question that comes to mind, and I'll direct it to you, Zameer, is the fact that all of these sort of systems that have now been implemented as if we've been living like this forever have been possible because government in part has had to redirect a lot of funds towards healthcare, right? If you look at the amount of money spent by government in the last year alone on healthcare comparatively to the last decade, 2 decades, you know, it's chalk and cheese. So it does take quite a bit of resources and sadly an emergency for us to think in this way. How do you suggest that we continue the systems that we've been designing, as you say, to deal with something like TB that has been around for time immemorial, HIV that has been around for the better part of the last 3-4 decades, and because it's now a lived experience for many South Africans, there is no certain amount of urgency that we've seen with this particular pandemic?
Yeah, no, thanks, Africa. I think it's a great question. I'm going to take the first half, but I'm going to put Gaurang on the spot with the second half of the question, because the one question is about resourcing, and you're absolutely right. Look, there was new funding that flowed into the sector, reprioritized from other parts of government. We won't take that fight on here because some people may not be happy, but it was obviously the right thing to do at the time. I think the other point, though, Africa, is that it leveraged other sources of funding too, and other sources of innovation and folks that were prepared to take on the risk. So, you know, the Solidarity Fund had made a significant contribution. The private sector really did step up and try and play its part to contributing. And then, you know, other players on the periphery of the so-called healthcare system did also step in and say, we want to play a role. And I think that augmented government's additional funding in the response. But the question really, I think, for Gaurang is what I saw was a sea change in the appetite to respond, be agile, and take risks and decisions that were not happening before. So, you know, certainly for me, some of the discussions, Africa, that were happening would have been impossible in February of 2020, became necessary, requested, and urgent in March of 2020. So, you know, just, I guess from Gaurang's level at the policy at national, it would be great to just hear his reflection on what happened there, and is this something that will stay?
Pressure, Gaurang, over to you.
No, thanks. I think maybe one perception to correct is that the health sector, certainly public sector, received additional funds. It wasn't we did receive additional funds, but it was no more than 5%, 5 to 8%. So it wasn't anything substantial. Yet we saw the impact we saw, and I think it's largely because, as Zameer says, the agility of response, the collaboration across society, the public-private, all just hands on deck, coming to the table, all trying to solve the same problem. And I think this was largely because of the pandemic, Africa. I think everybody realized that economy is not safe until the pandemic is there. So everybody was realized that unless we get this particular problem out of the way, we're not safe here. And really this call, which then became quite prominent, no one is safe until we all are, I think became very, very important. The one important issue to reflect on here is that the lines between communicable and non-communicable diseases became very blurred quite quickly. So a lot of people died due to COVID, but it's actually because of the underlying conditions that they died. Hypertension, diabetes, So the people that die, our numbers show that 62% of persons of deaths were among people 60 years and older. If we include the 50 years and older, that number increased to like 80%. But that is because majority of that population is carrying the burden of non-communicable diseases. And so this concoctment of burden of diseases really played out, and that the pandemic showed up. But I fully agree that if we all put our head down and say, listen, this is the disease we're going to prioritize as a country, it's likely to make a much bigger difference than it would otherwise. And agree, I think the need to try, trace, if we fail, we can only get up and learn again. I think there were no golden solutions to the problems we had in the country. But it was just the whole time the trial and error. And I think it's that learning intent that we need to walk into to solve a particular health problem. And I would agree that if we did the same for HIV, if we did the same for TB, if we did the same for other conditions, we are likely to have a better impact. Of course, one of the things that COVID has done has compromised other conditions severely so. And so there's even a higher degree of urgency to get those routine services back up to ensure that we reverse some of those damages over.
Gaurang, thank you very much indeed, and thank you to you, Zameer. You're obviously staying with us for the duration of this On the Couch session. If you have any questions for them, please use the chat function on the platform and we will pose them to you. Our next speaker is Dr. Michelle Mulder, who's the Executive Director for Grants, Innovation and Product Development at the South African Medical Research Council, and has been consulting for more than a decade on technology innovation through her own company, and has been involved in the strategic management and commercialization of the Medical Research Council's intellectual property, amongst other things. The very important question that she's here to answer today is how investment in research and development would help to build homegrown resilience on the continent. Because, Michelle, many people were asking, why were we not able to produce our own vaccine, and why did we have to wait for the United States, for France, for Canada, other countries in Europe and the UK to first be fully satisfied before we could get the scraps that were left over from them? Good morning.
Can everybody hear me?
Yeah.
So good morning. Thank you, Africa. Good morning, everybody, and thank you very much for this opportunity. I'm going to be presenting this morning on investing in health research and innovation. And my topic is really based on the premise that was presented to me, which is that localizing research and production within our healthcare systems would create this potential to build the capacity, to open opportunities, and build this homegrown resilience, as Africa mentioned. And I argue that it also will allow us to promote self-sustainability, reduce our supply on our reliance on global supply chains. But not only that, it'll also increase our access to appropriate and context-specific healthcare products. If they're developed here for our systems, our context, they're likely to be more useful. So my response, in a nutshell, is we are already doing this. So we've been investing in R&D, health R&D specifically in South Africa for decades. About 20 years ago, this was ramped up substantially with two major policies, the National Biotech Strategy and the National R&D Strategy. And it really continues to grow since then, and I'm going to show you some of the numbers. There is a strong political will and intent from departments like the Department of Trade, Industry and Competition and the Department of Science and Innovation and others to increase support for local research and production. But I have to admit that there remain deficiencies and challenges, and obviously one of them being that we're not currently manufacturing vaccines on the continent. And these are a barrier still to us realizing the full potential for this. So just some figures. There was a publication that came out last year from members of the National Health Research Committee, which really tried to understand what are we spending on health research and development in South Africa. The number they came up with was around 7 billion, and I think that surprised some people. I don't think some of the researchers knew that we were actually spending that amount in the country. And that's about 20% of the total expenditure on R&D. If we look at where this money is coming from, most of it is coming from the US, so that's largely the big NIH grants that our researchers are winning and CDC funding and so on. But the second largest local source of this funding is actually local. It's South African sources of funding. And if we break that down into government sources, the SAMRC is one of the largest local funders. So this is encouraging, but if we look at the targets that were set around the percentages of total health spend in South Africa that we should be spending on R&D, which is 2%, and the target set by the National Health Research Committee to spend 0.15% of GDP on R&D, we are definitely falling short of that if you look at the numbers below. So the MRC, as I mentioned, is the largest local funder of health research. Our mission is to improve the nation's health and quality of life by funding and conducting responsive health research development, innovation and research translation. Our income last year was just over 1.1 billion rand, and I think the important thing is that less than 20% of this goes to administration, corporate. So more than 80% of this money is going to research, development, capacity development, and innovation. And a key focus for us is translating this into health impact with new products, processes, etc. So to illustrate the change and this move in funding and the increase in funding, pre-2012, we had a few MRC-specific grant mechanisms around capacity development and research, our extramural research units, and really just a handful of strategic partnerships with others. In terms of innovation, we had a tech transfer office, which was very inward-focused, just looking after our own MRC IP. If we fast forward to after 2012, this is what the situation looks like now. We have a large number of strategic projects. We've expanded our MRC grant projects, and we enter into a number of strategic partnerships with other funders, so local funders, global funders. My colleague Zameer from the Gates Foundation is one of them, the Newton Fund, etc. A key one that I'll just mention in a bit more detail is strategic health innovation partnerships with the Department of Science and Innovation. And then on the innovation side, we have these specific funding mechanisms, but we also have, for example, a collaborating Centre for Digital Health Innovation. It's focused very specifically on innovating in the digital health space to ensure and provide for efficient health delivery. And then we also have hands-on mechanisms to help these innovations move through. So the Global Health Innovation Accelerator is looking specifically at global health technologies. And then MEDIC, which I'll mention a bit later, is a cluster program specifically for medical devices and diagnostics. So I mentioned SHIP just to show the breadth of the areas that we're involved in. SHIP is just one of the programs, and these are the different health priority areas that we cover and the different areas within those that we are funding projects in. So I just want to spend the rest of this discussion talking about some key examples, and obviously drawn from COVID. The one key one which is missing here, because we were not involved and I don't have enough information on it, is the National Ventilator Project, which I'm sure you're all aware of. So I'm going to talk about some of the ones that we're involved in. And my colleague Zameer mentioned the COVID surge testing, where we basically got a large grant from the Solidarity Fund to engage with local academic laboratories in South Africa to offer surge testing for COVID-19. So what emerged early on was that there was going to be this substantial demand every day for testing in the public sector as well as the private sector. NHLS, I think, in the beginning was a little bit overwhelmed. The turnaround times, we're looking at 1 to 2 weeks to get results back. And so we set up this program with 7 laboratories in Cape Town, Gauteng, and KZN, who were set up and sort of accredited, let's say, by the NHLS to offer this testing as a spillover testing service for them. We ended up, through this program, delivering more than close to 40,000 tests after June, and more than 96% of these were delivered within a turnaround time of 48 hours or less. Unfortunately, this program actually ceased in September, apart from just 1 week of testing early this year, because there was a reduced overall demand for testing, but also, actually, fortunately, the NHLS managed to increase its capacity and was, in fact, able to absorb all the demand and address that. And then also there was a Regulation 178 which came in, which was, well, it didn't come in, it was there already, but it was applied now to COVID, which required the laboratories to have a particular accreditation. So that also did delay things slightly. But also this grant was used to capacitate 3 historically disadvantaged institutions to be able to deliver COVID testing. So they received equipment, training, etc., in their laboratories to actually offer this testing. Although they never ended up conducting the testing in the end for the reasons above, this capacity has now been redirected to COVID research projects, one of them being the wastewater surveillance project, which you may know something about, which is really providing valuable information on the epidemic. The second example I want to talk about is a partnership we entered into with the DSI and Technology Innovation Agency. In May last year, we released a request for applications for specifically projects in South Africa where they were developing local reagents. So again, there were, at the time, real problems with accessing global supplies of reagents, testing kits. So we wanted to address 2 things. One is to have those produced locally, reduce our reliance on global supply. And secondly, to start to look at points of care tests, not the rapid antibody test, but rapid antigen and other tests, which allow you to detect for the presence of the virus on site before a patient leaves the clinic. So we ended up funding 7 projects. On the local kits, we funded a project with a CSIR and a company called Recent Biosciences, developing nucleic acid extraction kits. We funded a second project with CSIR and Cape Bio, and you may have seen the press release recently that has now been approved by SAMRC and is on the market. We approved and funded a third project, which is developing actual controls for use in these tests. And then on the points of care side, we've got 4 projects. One is a lateral flow test for antigen detection using what they call aptamers, and the other two are antigen detection kits using antibodies. And then finally, a rapid RT-PCR LAMP assay and a local system that can be used at points of care, and there's a picture of it, to deliver results within 15 minutes. As an alternative to PCR. So those tests are either have been submitted to SAMRC for approval or are about to be submitted to SAMRC for approval. And this is really another key example of how we're trying to localize, not just the research, the development, but also the production. The third one I want to mention, I mentioned that we have this medical device and diagnostic innovation cluster. This was launched earlier this year, and it's funded by the Technology Innovation Agency, and it falls under the MRC. And we released in June this year a request for applications to localize the manufacture of medical devices. And this is in response to the fact that more than 90% of medical devices in South Africa that are used are imported. So we're trying to address this with this pilot program, and we're now funding 5 projects which are directly aimed at replacing an import product that's already in the market. And those are the projects listed there. And then finally, I want to talk about, getting back to Africa's point about vaccine manufacture, the mRNA Technology Hub. And again, you might have seen the announcement. It was televised with the Director General of WHO and with our President. It's a public-private partnership consortium to advance mRNA vaccine production in South Africa. There are 3 objectives. It was done as an open global call by the WHO. South Africa won the bid. The first objective is to transfer technology to produce mRNA vaccines on a pilot scale at a company called Afrigen, based out in Montague Gardens here. And they will produce it for phase 1 and 2 clinical trials. They will then become a training hub for anybody globally to come and learn how to manufacture mRNA-based vaccines. And they've already had numerous requests from around the world. The second objective is to transfer that technology to the Biovac Institute, based here in Pinelands, to actually manufacture at scale for phase 3 clinical trials and for commercial use. And then objective 3 is running in parallel, and that's being managed by us at the MRC, and that's going to be in parallel developing the new candidates, those that are responsive to variants, those that are using new mRNA-based technologies, and we are driving that consortium to provide this pipeline, which will go into clinical trials and then hopefully move into the pilot production and full-scale production, all done in South Africa. So to conclude, I think, and this is really echoing what the colleagues earlier have said, COVID has demonstrated the need for and achieved a massive, globally collaborative scientific effort and a rapid dissemination and sharing of results and data, and I think at a scale we've never seen before. Our researchers in South Africa have pivoted very rapidly, taking the expertise that already exists, the platforms that already exist, to apply this to COVID research. And we as the MRC and DSI have also reallocated and raised substantial funding. I'm talking close to R750 million towards the R&D effort for COVID. COVID has also taught us the urgent need to establish capacity for local manufacture of not just PPE, medical devices, diagnostics, vaccines, etc. And because of that, these efforts were always an intention, but they've now been accelerated. There's no time to wait around anymore. We have to get this right. And then finally, COVID has demonstrated the need for collaboration, cooperation, agility, and a rapid response. And this has been achieved, from my experience, on an unprecedented scale. The projects we've been involved in, the amount of collaboration, the agility, the ability to move quickly has really been unprecedented within the MRC and outside as well. And we have to, again, to my colleague Zameer's point, make sure we harness this. We have to take those lessons, the capacity that's been built, the new ways of working, and make sure we don't lose that and we move towards full localization of research and production. Thank you.
Thank you, Michelle. Thank you very much indeed. And I suppose my first question then becomes, how do we ensure that? How do we ensure that we harness this unprecedented level of collaboration, of working together, sharing information and data, which in the research and development space, I mean, that's your currency, right? The amount of data that you're able to get together.
So, I mean, I think the key thing is to let's see these things through to completion. And the will is there, the investments have been made, the momentum is there. So there's no reason I believe that this will be lost. In terms of data sharing, everybody, I think somebody mentioned earlier, has become an expert on COVID through Facebook, through Google searches. Results of studies are coming out in preprint before they've even been reviewed, which is actually not necessarily a good thing because a lot of rubbish is coming out before it's been properly peer reviewed. But what it means is that information is getting out there. The journals are publishing open access. You're no longer having to pay, to access these scientific results. And I don't believe that will change without resistance, strong resistance, because it's shown what can be achieved in such a small amount of time. To get a vaccine on the market from identification of a sequence to full clinical trials in a year or in fact less than a year, is unprecedented. And I don't believe that anybody has the will to lose that, and there's going to be strong resistance if things go back to the way they were.
Now, COVID-19 is not the first coronavirus to hit the world, perhaps not at the same scale previously, but certainly coronavirus have existed before, and one has to then assume there will be another one. And I imagine the technology that we've developed and invested in will then be usable for a future coronavirus, right?
Yeah, no, absolutely. I think the lessons learned, and I mean, as I mentioned, the researchers in South Africa have rapidly pivoted to studying COVID-19. No, it didn't exist before.
Yeah.
And these are researchers who have built up this capacity in the HIV space, the TB space, non-communicable diseases. So they have the capacity. They've been studying immunology of HIV and other viruses. So if you can do that for those viruses and you can do it for COVID, you can do it for the next one that comes along. So the capacity is there, and it's just a matter of pivoting and prioritizing. What you're researching.
And can you do it for something like Ebola, for example? Because the theory was, because Ebola was affecting West Africa primarily and not so much Europe and America, certainly not to the scale that COVID-19 has, there was no urgency to it. There was no outpouring of investment, research and development around getting a treatment for Ebola.
Absolutely, and in fact Ebola has been the stepping stone also for some of the COVID vaccines. So some of the platforms used for the COVID vaccines have been actually used in the response to Ebola. And one of the things that Ebola did invoke was this global need for epidemic preparedness. So CEPI, which has been very large in the response to COVID, was established actually as a result of Ebola. I attended a meeting in Hong Kong, I think probably in 2018. No, in fact, I think probably closer to 2016, where it was all around, we didn't respond properly to Ebola.
Yeah.
Let's not let this happen again. Pharmaceutical companies, WHO, research groups, everybody, NGOs, they all came together at that conference to talk about epidemic preparedness. CEPI has been around for a number of years, and these groups and discussions have all been in preparation for this next pandemic. I think we still got caught a little bit unawares and perhaps not as prepared as we needed to be, but the stepping stones were there.
Which is good. It's good to learn that.
And they stemmed from Ebola.
It's good to learn that there's so much research that is actually going into this space. Thank you very much, Dr. Michelle Mulder from the South African Medical Research Council. As indicated, of course, she'll be here until 12 o'clock. So if you have any questions for her, you're most welcome to use the chat function on the platform, or even use us social media if you like, using the hashtag, of course, Co-Create Design Festival. We'll pick up those questions and direct them to her. We now go to the Netherlands. Dr. Simona Rocchi is a Senior Research Director for Design for Sustainability and Innovation at Philips Experience Design. We're pretty much talking about how technology can be used to, I suppose, address the issue of COVID-19 and emergency pandemics that we're responding to. But here, how do we use technology to really improve and create a more inclusive healthcare system? Simona, you might or might not know, but South Africa is very much one of the countries with the highest economic income disparity, if you like, and we have a very well developed and designed private healthcare system with some shortcomings and a very overburdened and some would argue under-resourced public healthcare system that deals with 80% of patient care in South Africa. We're looking for ways of how we can use technology to really make sure that a Gogo Dlamini from Khayelitsha receives exactly the same level of care and quality of treatment as a Mrs. Smith from Constantia. How do we do that? Good morning.
Good morning. 1 million questions. First of all, thanks a lot for your introduction and for your welcome. I'm really delighted to be part of such a multidisciplinary group and to talk about some important topic today about access to healthcare. And my contribution today will reflect the private sector perspective. In particular, some of the learning that we developed within Philips when innovating to extend the reach, in particular with application and solution that can also make a difference in low middle income countries. Today, I will focus on the Africa continent, so not specifically on the Africa, on the learning in general on low middle income country, but for sure, I will touch many of the points that also the previous speaker have addressed before me. And I will also use to contextualize our approach some very tangible practical example and some also in use in South Africa in the space of mother and child care. That will make more a little bit live my story, let's put it this way. So let me start first of all to contextualize our approach, the approach that we use in our company. We know that despite economic progress and technological advancement, in reality, we still live in a world of inequality. And this applies both in low middle income countries and high income countries. In particular, this disparity are also reflected in healthcare. We know that more than half of the global population still lack access to healthcare services that we need. And in particular, we experience lack of qualified doctor, medical staff, especially in low middle income countries, that are essential to provide quality care, like also the previous speaker was referring before. So the problem that we are facing is very complex. We need to extend the reach to provide care, but I would say affordable quality care. So a key question also for a company like Philips is what kind of innovation we really need to embrace to create an healthcare outcome that is affordable, but is also sustainable over time. Any innovation comes with a price. And we need to ensure that the innovation has an impact on the ground and they can sustain the kind of value that we we bring forward. So already WHO indicate very clear direction to walk the path toward universal care coverage. And for me, there are a few important points in their advocacy statement. One of the key points is a good health system are rooted in the community that they serve. Also, the previous speaker mentioned that health need to start at the community level. We really need to start where people live, and is essential to put in place good quality primary care services where people live. So how we can reach them in a very prompt way. First, second, there is also in the post-COVID period a shift from just the treatment to prevention, preventative care. In particular, also an attention to create a more healthcare awareness for behavioral change. This is really essential if we want to create a more inclusive and equitable care. And is really in line to this transformative mindset that also Philips started to extend its portfolio, moving from treatment and diagnosis, traditionally, places in tertiary care setting, towards also tools for preventative care, for first-time right diagnostic on community, at community level, and also tools that can support healthy living. The health care system strengthening, service delivery strengthening need to come along also with an awareness in a community we're supporting healthcare demand. The two aspects are basically the two faces of the same coin. In order to bring forward this challenge, synergetic action, we try to combine the force in Philips between our commercial proposition from the business and also the initiative that the Philips Foundation is bringing forward, healthcare demand and healthcare delivery, to have more a comprehensive approach. And it is essential in doing so, before also was mentioned, that we create alliances across sectors. We need to work with NGOs, with development bank, with the new funding mechanism, new business model, and we need to create a new private partnership with the local government. And I would like to show some of these couple examples how we act on this innovative space. And I've chosen also one very provocative case. We talk a lot about high-tech technology advancement, but I would like also start with the high-risk pregnancy toolkit. That is an innovation that we co-developed together with the International Committee of the Red Cross for fragile setting, for setting where there is no access, so very limited access to electricity and connectivity. In particular, to look at the space of antenatal care or maternal care. On the left side, you see very simple paper tool. It's a paper tool that the green part tries to raise awareness on community level on healthy practices during pregnancy to support a more lifestyle change. The red card instead contains pathology, discomfort from the doctor, indicated by the doctor of RCRC, that can help community healthcare worker, formal or informal, to identify pregnancy that can lead at high risk and to support prompt referral. For me, these are two very important tools because it really try to leverage people that are on the ground to create more efficiency and effectiveness in their task, in particular also in prompt referral in the identification of pregnancy at high risk. The fetoscope, actually the double-head fetoscope that you see here in the center, I think is one of the most diffuse tools that is used by midwife in low resource setting to perform antenatal care visits. In our case, was just a very simple people-centric innovation. We created a stereo function that enabled both the woman and the midwife, when the midwife performs antenatal care visit, to listen the sound beat of the baby. And one of our aim was really to try to improve the patient experience, to motivate the women to attend antenatal care visits that often in very low resource setting are avoided, are not attended. So these are a very simple innovation that can make a difference on the ground. And although they seem very low tech, in reality they contain quite some high clinical content that was provided by the medical domain. And in order to scale, for instance, the card, we definitely leverage a digital platform. Also before it was mentioned the power of this digital platform for dissemination of information, for the dissemination of tools. SAMRC is scaling now the tool, the paper tool, in all its country of operation, thank you the online primary care digital platform they've established in their primary care facility. Concerning the double-head fetoscope, that's still under test in Kenya, and then it's been demonstrated to be also beneficial during COVID, because it allowed also to keep a certain distance between the mother and the midwife. We also leverage 3D printing technology for local production. And also one of the previous speakers before was talking about the power of local production and manufacturing. So I think also health and wealth are two faces of the same coin. They need really to come together. So for me, these are two elegant ways to bring forward innovation that in certain settings cannot just rely on high tech. But let me move to more stable contexts, like also, for instance, the South Africa context. Still, in some situations, there are challenges in terms of access to connectivity, in terms of access to electricity, in particular also the cost of data is quite tricky. But in a more stable context, and a little bit more advanced context, in order to support also antenatal care, we have developed two applications that can be used in isolation, but also together. One is called the MOM, the Mobile Obstetric Monitoring Solution. It basically is an application that midwife can very easily download on any portable phone to conduct the NC protocol, to collect the data at home or in the primary care setting, to store this data in the iCloud and to transfer to higher level of care, for have a consultation with obstetrician, to have a remote monitoring. And this is an essential tool to support task sharing, in particular from tertiary to secondary to primary care, if we want to deliver quality, affordable care. This application can go together also the Lumify portable ultrasound, that is a high quality images ultrasound that indeed can be given in the hand of the midwife to perform the antenatal care visit, and indeed via telehealth situation to connect, in this case, also to higher level of care for prompt referral in case the pregnancy is detected at risk, or to have a constant monitoring by specialists. These are only two of the applications that we try to bring forward and I use the case of mother and child care in relation to the need to create more inclusive and equitable care. However, as I mentioned at the beginning, the challenge is very complex, is vast, and is of systemic nature. So there is no single intervention in isolation that can make the healthcare outcome that we desire. Therefore, we have created what we call the Community Life Center collaboration platform, where we bring together our innovation, our technology, can be low-tech or very high-tech, very sophisticated, initiative from NGOs, also for healthcare demand creation, for healthy living, with also the resources from the local government. Are a collaborative platform that we bring together different programs, different solutions, and complementary expertise to try to provide primary healthcare services on the ground. What we do, we upgrade primary care facility already existing, but they are not trusted, are not properly functioning, or we establish new facility together with our partners on the ground. And of course, the form of the facility depends very much, first of all, on the contextual need. We are focusing just on antenatal care or non-communicable disease, or even emergency situation like it happened during the COVID period. And the shape also that take place is different. Here I use also some examples that have been implemented in South Africa. Can be mobile clinics or can be more permanent facility. It depends very much on the type of collaboration and partnership that we put in place. And the challenge that often is to ensure that these facilities are operating in the best way is really to check if the devices are properly working and if the service is properly delivered, is properly utilized. So we have also introduced what we call the MEL, the monitoring evaluation software that enable remotely, first of all, to try to predict failure in the equipment, to have a proper immediate response for maintenance. We know that a lot of devices are in place, but they are not properly working because they are not properly maintained. So we try to address also this issue. And from the other side, also, we try to monitor the service performance, the delivery of the service. So this is just an example of how also remotely we can try to detect or to support efficiency in service delivery. These are on a glance, very, very briefly, a few examples of how we approach innovation, in particular to create a more inclusive and equitable care. Of course, the lesson that we got are multiple. I'm looking also to the time. I want also to leave some space for the debate. But for me, one of key takeaway that I would like to bring forward also in this discussion is the fact that, like also some previous speaker mentioned, that innovation starts always with people. It's very easy to fall into the trap that just new technology, you put in place new technology and we resolve the problem. We learn that is not the case because they are not sustainable, they are not affordable, they don't create the impact that we desire. It's extremely important that we think what kind of technology we need to put in place to maximize the outcome, and we try to leverage people that on the ground as much as possible. To have a people-centric approach is key. And equally key is to create the right collaboration platform, the right agreement to synergize action and activity, even initiative, to maximize the impact on the ground. This is just on a glance what I wanted to share with you today.
Thank you very much indeed. What is exciting is the fact that a company as gigantic as Philips is, and whenever you think of Philips, you think of super edgy technology that is going to be slicing through the most minutest of cells in order to bring about health, and yet you're investing in a way and in technologies really that are primary, somebody might argue. What made Philips decide to go this route, to work with communities, with NGOs, to realize the kind of solutions that you've presented to us today?
Well, again, let me go back a little bit from our root, and many people grow up with Philly with the television or with the radio. In the last few years, we refocus our portfolio on healthcare, and we deliver healthcare in the hospital domain and the home domain. However, being a health technology company, we cannot deny that half of the population still need access to healthcare. Right? So traditionally, we serve more the high income level situation, let's put it this way. So in order to provide a good quality healthcare, you need to invest in innovation. And also the app that I show you, also the system, the digital system and digital connected strategy is key for us. For us, we really invest in connected primary, secondary, tertiary, and community care. Is essential to deliver outcome. We learn that if you just put an ultrasound, top quality ultrasound, in a facility, but you don't invest in training, you don't create also healthcare awareness on proper practices, to have the best outcome, you will fail, and more the system, also the healthcare space, go towards value-based care. In value-based care, you need to demonstrate outcome. And to demonstrate outcome, you need to demonstrate that the service utilized, indeed the service is beneficial to the doctor, to the patients. So it's fundamental to start to think more carefully what kind of technological innovation we put in place. Need to be appropriate for the doctor, appropriate for the beneficial, appropriate for the different level of care. And in particular, they need to enable task sharing. But also what we learn in a hard way, that social interoperability, even more important than technical interoperability. I mentioned that one of the core strategies is digital connected care. And like everybody, to connect a different devices with different platforms is really an headache. But also we learn in the hard way that we need to understand the level of the capacity on the ground to be able to use this technology. We have to have a very easy of use interface. We need, of course, to upgrade the skill, but transformation, social transformation is a slow process. So this is why I also, by choice, use this more provocative low-tech case to open this conversation. But of course, we invest in AI, in data sharing, but everything comes with a cost. So the point is how you create impact, an impact that can be sustainable over time and create a result.
Dr. Rocchi, thank you very much indeed for joining us this morning. Dr. Rocchi, of course, is a Senior Research Director of Design for Sustainability and Innovation at Philips Experience Design. Our final speaker for this morning is Russell Rensburg, Director at the Rural Health Advocacy Project. He is an expert in health systems and policy, was a commissioner at the Lancet High-Level Commission on Quality Healthcare, also manages the Rural Health Advocacy Project's Rural Proofing Program, which advocates for the equitable allocation of resources for rural healthcare delivery. We are going to be speaking about the solutions that the citizens of South Africa can bring to this important question and how we can design systems that will get us to where we want to. But I imagine you were very excited about Dr. Rocchi's presentation, right?
I think I was very excited about the idea that the presentation presented. But I think I sort of stood there still thinking that health is pretty much a very basic business. You diagnose, you treat, and that's it. And I think over the last 100 years, we just figured out ways to do it better. But it still focuses on health care, right? And 80% of health is actually not in a health center. It happens in our communities, right? And I think that's part of the problem when we start looking at health crises. And we've heard some fantastic examples of how we respond to that diagnose, treat, and then create a vaccine to a particular response. But what we didn't talk about, and maybe I want to open my presentation with that, is that without actually addressing the broader determinants of health, the impact of these pandemics are disproportionately felt by the poor. So yes, we had a lockdown, we contained, virus spread, the first wave was more of a deluge than a storm. The second wave, things got ugly. And as I'm speaking today, officially 90,000 people lost their lives to COVID, right? But those are only the official diagnoses. So if you had an official COVID diagnosis, that was registered as a COVID death. Our colleagues from the MRC have been, since the beginning of the pandemic, tracking excess deaths. right? And excess deaths are those deaths that occur above the average for a particular period, right? And those run now almost 3 times as much as the official COVID deaths. So 257,000 people died, or excess deaths from what normally would occur, right? So just like some simple mathematics, and we say just maybe 80% of those excess deaths can be allocated to COVID. More than double of the official people died with probably never reaching a health facility. Some people died in waiting rooms because they came too late, right? But I think I prepared a couple of slides sort of just to go through that conversation. But as much as COVID was a success around solidarity, it was also something that really just placed the spotlight on the major challenge of our society, which is addressing the impact of poverty and inequality on the livelihoods of the greater population of South Africa. So I thought maybe what I could do is like take a moment and sort of just take us back. You know, South Africa has a very long, complicated history. You know, we've had, since 1951, we've had sort of separate development, where we've developed different people, different identities, apartheid, and it has had a long and lasting impact in who we are as a people, right? We transitioned to democracy in 1994, and in 1996, we completed our constitution, right? So in the preamble of our constitution, we enjoin ourselves to this vision of a country that we want to create, right? So in the preamble, we talk about, we commit ourselves as a country through our leaders to heal the divisions of the past and to establish a society based on democratic values, social justice, and fundamental human rights, right? On that basis, we lay the foundation for a democratic and open society in which government is based on the will of the people and that every citizen is protected by law. Every citizen is protected by law. But most importantly, we enjoin ourselves with this big idea, or the South African dream, to improve the quality of life of all citizens, or all who live here, and free the potential of each person. Right? So poverty is not a choice, it's an accident of birth. You know, we don't decide one day, okay, I'm going to get born today, I'm going to be lazy, or different kinds of things. It's an accident of birth. You know, it depends who you're born to, what the trajectory of your life should be. Right? And I think when we start looking at as a big global crisis like COVID, it's sort of going back to those first principles. What is the problem that we as South Africans are trying to solve? And what is the importance of developing a broader base that can allow us all to develop into the kinds of, or the full potential that we can be? You know, earlier we were talking, I come from Kubera. I'm still struggling to pronounce the name of my town. You know, and interesting, it's the first Khoi name in South Africa, which is part of my heritage. But I come from there. I'm a son of a factory worker and a mason, right? And by accident of birth, I was born at the right time, right? So I came of age as we transitioned into a new country and a new dispensation. I went to university in 1992. You know, I was part of that whole euphoric idea of we could do anything, right? And over the next 10 years or so, many of us that were born in that time had an opportunity to actually jump, like what they call it, intergenerational mobility, right? So I didn't become a factory worker. I was able to get a degree. I was able to have a better life. I moved to the suburbs. You know, my children, I have 4 kids. So I become invested in this idea of development and growth and what it means for everybody. But since then, things have been a little bit harder. So in South Africa, we can't talk about anything without really talking about the elephant in the room, which is poverty and inequality and unemployment. Right? So when you look at the graph, the top is us, right? And it tracks us from 1993 to 2007, and except for a small little dip, just post-freedom, where we had drops in inequality, it's generally risen. The blue line at the bottom, this is a slide from the International Monetary Fund, is tracking levels of poverty and inequality in other emerging economies. It doesn't take a data scientist to see that freedom hasn't really delivered the change that we wanted to see. In some ways, it kind of reinforced economic apartheid. Then, this is our population pyramid. Right? And from here you can notice that Almost half of our population is under 35. Right? So we have a very youthful population. Sadly, when we look at unemployment, almost 60% of young people who are so mostly black and poor are structurally unemployed. Right? So any amount of like high-level economic growth is unlikely to absorb those people into the economy. Right? Because they lack the skills. Almost half of them haven't completed matric. Right? And a lot of that time, that's as a result of not necessarily having access to a health service. So think about it for a moment. I think there's about like 600 optometrists in the public service. So you're a little kid, you're living in Citrusdal, right? You have trouble seeing. The education system will treat you like you're stupid and the teacher's got 40 other kids that she needs to worry about. You go through life thinking that you're stupid, you end up dropping out of school and poverty gets perpetuated, right? The same for young women. We have an indicator in our national health indicator sets that tracks pregnancies of young girls between 10 and 19. 10. My youngest daughter's 14, right? I can't imagine her with a kid. But for many, that's like a daily reality. You know, it's 14, 16, that's when a lot of teenage pregnancies occur, and often women end up having their vulnerability increased because they can't access sexual and reproductive health services from a health system that doesn't necessarily respond to their needs. We also have a very strong primary health sort of platform. We have over 3,500 clinics. But if I had to go into that clinic and say, listen, my brother's struggling with addiction, which is a big problem in our society today, substance abuse, alcohol abuse, drug abuse, we don't have a health response for it. Our communities also one of the things that came out of COVID was a drop in trauma cases, right? Because we didn't sell alcohol, and I'm not a fan of prohibition or anything like that. But it sort of put a spotlight on the extent to which our health facilities are spending time dealing with the consequences of poverty and inequality and how much resources that takes. I remember a story from Grooteskier where the drop in gunshot wounds actually freed up capacity. You know, I don't know how many medics there are in the room, but it takes quite a lot to repair an injury as a result. And surprisingly, you know, the leading cause of death amongst young men in some rural provinces is, guess what? Interpersonal violence, right? And yet, as a primary healthcare system that we have at the moment is not designed to respond to dealing with that levels of trauma, which poverty unfortunately perpetuates. So, but what is health? Health is not healthcare. Health is not just really about responding to diseases or finding a diagnosis and finding a cure so we can carry on with our lives. This is from the Alma Ata Declaration, where we looked at the primacy of primary healthcare and what it means. And according to Alma Ata, health is a state of complete physical, mental, and social well-being. It's not merely the absence of disease or infirmity, right? So health is much more holistic than what the healthcare system has segmented into. You know, so we have 4 different categories in South Africa responding to HIV and AIDS. And then we provide antiretroviral drugs for people living with HIV, and we extend their lives. But we have the right to food, but nobody realizes the right to food. We have no social security really beyond for people between 18 and 49 that don't have a disability. Right? So if you're unemployed and you saw their unemployment levels, you almost have no income. Right? So you could get HIV drugs, but you wouldn't get any income support to buy food. Because it's your job to find a job. If you can't find a job, you're lazy. You know, you can't be dependent on the state. But if you're structurally unemployed, the economy can't absorb you. So what happens to you? Right? How healthy are you if your life is extended, but your misery is increased? And then maybe just to illustrate this point, unfortunately, the diabetes thing in this particular graph, this comes from a study that was done by Di McIntyre and John Atakuba, where they developed a diagnostic report to sort of just look at poverty and inequality in healthcare in South Africa. Now, health follows a social gradient. And what that means is the poorer you are, the less likely you are to access care, despite showing a need for it. You know, so across all of those diseases, the bottom half is the ones that are affected by the poor. Right? In this one, diabetes is seen as a lifestyle disease. But we had model data in 2010, and currently the diabetes prevalence in South Africa is close to 10%. So in the adult population, there's roughly 3.54 million people living with diabetes. And of those people, only a third are on treatment. Right? And we saw from COVID, and people told us earlier, that the leading cause of death related or comorbidity with COVID was hypertension, which is diet related. So eating hard to processed foods with high levels of salt contributes to that. Diabetes, right? Which, I mean, sugary drinks. You know, we have a sweetened sugary tax. At the moment, it tries to augment behavior around that by increasing the price of sugar-sweetened drinks, and reducing the sugar content by incentivizing manufacturers to not pay the tax by reducing the content. But diabetes is a major killer. It's the third leading cause of death in South Africa. So, like I said earlier, health is not necessarily just disease, or disease is not just determined by picking up a virus. Sometimes 80% of healthcare happens within our communities, within our settings. In 2010, the WHO published a fantastic report on the social determinants on health, which was authored by Michael Marmot. I remember reading it, and it was fantastic, and I thought everybody should be doing this, and that now all we do is we refer to the social determinants, but we do nothing about it. I think yesterday we spoke about this idea of education, right? And education's failed. We spend inordinate amounts of money on education, and we don't get the return. But I think sometimes we're blind to the fact that 80% of the kids in our education system come from very poor homes, right? So even educational outcomes are socially determined. You know, so if you don't have access to nutritious food, like in your first 3 years, if you don't get the correct nutrients, you become developmentally delayed, which means your ability to learn is impacted. So your poverty gets perpetuated again because of an accident of birth. You know, it's got to do with your income stability. If you have no income, right, it has an impact on what you can do in terms of healthy behaviors. I once heard a story at one of the conferences where we were talking about the response to non-communicable diseases. And let's say we call a NOMSA, right? And I say NOMSA lived in Khayelitsha, right? She had a job as a domestic assistant in Sea Point. Her madam or her employer liked to be served her coffee in bed before she went to take the kids to school. And what this meant was that NOMSA had to get up at 5 o'clock in the morning to be able to take the taxi from Khayelitsha into town and then onto Sea Point to be able to get there to make the coffee and to fulfill her obligations. Sadly, NOMSA's 3 kids then at home had to then tend for themselves in the morning in terms of organizing their breakfast, or they would get a little bit of money. So what would they do? The taxi rank becomes the commuting point. The only convenient food that you can eat is maybe a magwenya with some ultra-processed meats in it, which is high in salt. And, you know, so that diet that makes you feel full, but it's nutrient poor. And you end up being undernourished, and you're much more susceptible to disease. You can see the community environment. There's no place to play. So when NOMSA comes home at night, at 6 o'clock in the evening, they can't take a walk to the park because it's poorly policed, or it's just not set up in a manner to make the place livable. So in the end, poverty just ends up perpetuating itself and creating this massive risk in South Africa, where unless we find out a way to bring that bottom 60 or 80% into our conversations about the shared future, these kind of crises that we're experiencing will continue. And if you remember from the population pyramid, people over 40, from 40 upwards, we start declining. So if we fast forward 10 to 15 years from now, without making the right kind of policy shifts and changes, when it comes to health, when it comes to education, when it comes to housing, when it comes to even social security or income support, we could have no country to contest about. And all we'll have is these beautiful little properties out in Clifton, but no real economy, because we wouldn't have been able to retain the kind of skills to take us forward. But we have to change our perspective. So when we think about healthcare, we often just think about health as a very specialized kind of space. Only doctors and nurses and pharmacists, and those are kind of people that we think are health professionals. So you mentioned Ebola earlier. So one of the things that came out of Ebola was that researchers started thinking about how do we respond to shock. So what happens when there's an exogenous shock, right? So all of a sudden there's an epidemic that you knew was coming, but you were planning for it, but nobody expected it to come now, right? So it then has an impact. So like COVID was one of those exogenous shocks. I struggle a little bit with that word. It was something unplanned for, but it had an impact beyond just health, right? In the end of March last year, the streets were quiet. There was no economic activity. For us as the privileged and the professionals, we got all kinds of support, right? We had reduced interest rates, so we had more money in our pockets. We had less transport expenses because we worked from home. When we did our tax returns now, we got another credit for our home office, right? So in many ways, our lives continued. I think the problem that we experienced was we all developed a bit of a COVID tummy, but we were mostly at home. We watched all the series on Netflix. But for people in the rural communities where a lot of our advocacy is, they weren't so lucky, right? So while we did have income support, like a social grant of $350, which for someone who's never had any money that they had control over, was a massive, gift of dignity. $350 to you is lunch, but to someone that has no income or has never had any income of their own, it made a huge difference, and that's why the demand for it was so great. But I think the thing that we underestimated was the social systems or social solidarity amongst the poor. So many of us are economic migrants. So I'm from Kubera, Kubera. This Western Cape has something to do with our pronunciation, but right? But what we didn't really factor in was just how vulnerable these communities were. So a lot of us that migrate to the larger metros often still send money home, right? Some of us call it black tax, other ones, it's just money that you send home, right? But because we were working in restaurants or places like this, our income also dried up, right? Our UIF payment didn't even cover our own expenses, and as a result, we couldn't send those transfers home. So unfortunately, what happened during COVID is, despite our best efforts, we ended up looking after the rich more than what we did about the people who were really at risk. But the opportunity for us now is really to start thinking, okay, now, knowing all of these things that we know now, we know that we can collaborate, we know that technology is a great leveler, we know that we have to invest in social system if we want to have a shared future. How do we use this crisis to start thinking about how do we deliver healthcare differently? And how do we think about health, not just about the treatment of disease, but as an enabler of social progress? So the researchers looked at these three different areas around what are the things that we want to understand from a design basis better. So when we think about health management information systems, normally at the moment, like I told you, I have that indicator that I look at every year, whether it's going up or not, because it shocks me. Pregnancies between 10 and 19. But there are also other things like, so right now I'll start looking at whether we can start collecting routine data on diabetes. But we need to know what we know, and we need to know what we don't know. Right? So what we don't know is that we have all this data, but we have no intelligence. Right? And there's an opportunity for people who are maybe sitting outside of the health system to start thinking about the data. But let me just stop there for a moment. I think the cross-cutting thing there is around values. Right? Our values is really entrenched in our constitution. The leadership and governance stuff is things that we've been talking to death about in South Africa. And I'd like us to probably talk more a little bit about management, which is about planning, organizing, and controlling, right? Rather than just talking about leadership, which is very ponytailish. Everybody believes it's something else. But sometimes if we want to do more with less, we have to be more like the Dutch and have a very efficient football system, 4-4-2, and apply it to management. Plan, organize, control, and be very clear about what you want to achieve. Be very clear about which population has the greatest need, and be very clear about how you will reach them. Right? Your values in our constitution, we guarantee everybody, or guarantees everyone the right to access healthcare services, but we learned now through COVID that the right on its own doesn't guarantee you access. Ultimately, in a crisis, the person with the ability to pay is the one that will get the care. One of the chilling statistics around COVID was, like I said, 56% of the tests, diagnostics, were done in the private sector. Right? So our out-of-pocket health expenses in 2010 was probably 10 times higher than what it normally is. And we spend 25 billion out of pocket already on healthcare. Right? And the average cost of a test was 350 to 700 to 1,000 rand. But 56% of those tests were done in the private sector. 1 minute. Okay, sorry. Right? And then, so health information systems is really just about understanding better, but what is the information that we need? Is the kind of information that we have at the moment enough? Is it telling us the things that we need to know? You know, do we have the right kind of systems to translate this warehouses of data into some kind of intelligence that we can translate and use at to plan our services at the local level? Right? Because every district in this country is different. There's no one size fits all. What happens in OR Tambo is very different from what happens in Nelson Mandela Bay. What happens in Cape Town? Cape Town, often people talk about the Western Cape, but the Western Cape is 60% the city of Cape Town. What is it like up on the West Coast? You know, is life, there we don't even have district hospitals, we have district surgeons. And many of those district surgeons are still remnants of our old system, and they apply the same biases in the treatment of people. So when you go and get evaluated for a social grant in Lutzville, right, you'll be seen by a retired medical officer who will have his biases about deciding whether you're disabled or not.
You do now have 2 minutes.
I have 2 minutes. Okay, I'm sorry. I get a bit carried away. But health information systems to help us understand what we know. Can we translate the data from data into intelligence? And can we use the intelligence in our design processes to develop better responses? Health financing. You know, I think the introduction of a basic income grant can contribute to better health outcomes. Because as incomes rise, our health seeking may improve. Right? Is our current models of approaching to the way we finance healthcare still appropriate? 60% of the money that we allocate in the public system goes to spending on hospitals. Yet our colleagues from MRC did a study recently assessing health management information systems, or just in advance of, what do they call it, DRGs? Right? And they looked at some NHI pilot districts, and 60% of the hospitals couldn't produce discharge records. So if you're not producing discharge records, how do you know what you're spending your resources on? Are you spending your resources efficiently? And again, that's where just sometimes simple management and use of information systems can actually improve equity and expand our healthcare services get delivered. We have to look at our food environment. You know, ultra-processed foods are a significant risk. We saw with listeriosis. We didn't even know this disease existed. And all of a sudden, a bologna factory in Limpopo had a health safety issue, and it led to how many deaths? I can't remember. It was quite a few, right? But up until then, who knew bologna could kill you? But I think we need progressive taxation systems that looks at addressing some of the issues with our food. So ultra-processed foods that are high in salt and in sugar needs to be taxed. We need to take that money and invest it into other things. We have to look at our integrated planning around investments in infrastructure to create jobs. You know, we have 60% youth unemployment. If we build a hospital or repair a hospital in a rural area or in a township, that hospital can act as a catalyst for skills development. If we set conditionalities in terms of how we build our infrastructure. So if we award Joe Soap the contract to build a 150 million rand hospital over 5 years, we can put a conditionality on and say, look, at the end of the 5 years, we want to at least see 300 young people from that community being trained in anything from project finance to plumbing to electrical and so forth. And I think, lastly, health workforce is not just doctors and nurses or researchers or people with medics. You know, we need community outreach workers. We need app developers. We need people to start design processes that allow communities to engage with us in a different way. We need to stop thinking of the health system as an instrument of power, you know, where you have to follow the rules, you have to keep quiet and listen, and really start creating an environment through the way that we set up our structures that actually looks to solve the problem with the person that you come to see. I think all of you, when you go to the doctor, you'll sit there, he'll ask you 5 questions, and then you'll write the script, and then you'll go on your way. I think one of I said, we have 4 kids. One of the most chilling experiences for me was with the birth of our first kid. You know, we went, and then the next day, then the pediatrician comes and he does his rounds, and he has all these little attendants walking around with him. They look at the chart, he talks to the attendants, and then he moves on. He didn't speak to us once, right? And he was talking about the baby, saying, oh, the heart rate is a little bit irregular. And my wife nearly died, but it sort of got into me this notion that we really need to change the language around healthcare. We have to make people part of the solution and not the subject of the solution. But I think in closing, what I want to say that investments in social infrastructure like healthcare is an opportunity for us to start reimagining the collective future we want as a country. By investing in health, we can enable people to be able to live to their fullest potential. We can create opportunities for training. We can create opportunities for looking at our social systems and ultimately even our politics. Right? Our apathy is directly related to the extent to which what the system gives back to us. At the moment, most of us don't even care about politics. And that's to our peril. But I think we have much more opportunities than problems. And I'd like to leave you with a thought, which is really just built around this idea that sometimes wicked problems is not always about a solution. Sometimes it's just about a change in perspective.
It's a good thought. Thank you very much indeed to Russell Rensburg. I think giving us much food for thought in really, which is what this is about, right? We live in a country that is so complex in its output and lived experience every day, and in thinking about systems of healthcare to respond to those needs, one has to understand the complexity. So Gaurang, perhaps let me come back to you. You in policy coordination, are we seeing government appreciating, not only because of COVID-19, but generally, that we need to start reimagining and rethinking the system of healthcare in this country and how we output it?
Yeah, I think so. Africa, I really think that there's been an enormous spotlight, I think, as Russell has said, on the upstream factors that contribute to negative health outcomes. I also think there's been an enormous focus, certainly in the last 3 to 5 years, on the need to ensure that the patients are not lost in care once they're on care. And so I think the two angles combined are likely to give us better returns. We know the economic problems both locally and globally are quite severe, and we know that COVID-19 has just made things a lot worse, not better. And so I can't see South Africa improve health outcomes unless we do things differently. Over.
Is there an appreciation, though, Gaurang, that we are going to potentially put in quite a lot of investment now, but that system better be so good that when my 7-year-old nephew needs to access healthcare, it shouldn't matter really whether he has access to private healthcare or public healthcare. In fact, public healthcare should be so good that he'll get all of whatever his healthcare needs are going to be in 2035, provided for by a system that we're designing today.
Yeah, no, absolutely. So Africa, what we actually should be saying is that it shouldn't matter which provider you're closest to. You should be able to access the care that you need, irrespective of the fact that whether you have the money to pay for it in your pocket or not. I mean, if you look at one of the things that has been a spin-off from the COVID-19 vaccination program is exactly that. It doesn't matter whether you belong to a medical scheme or not. You can walk into any vaccination site today and not pay a cent towards that service. That's really the care we imagine for all the other healthcare services under the UHC vision we have.
Dr. Rocchi, you were listening to Russell here, and you saying that the CLC platform addresses a lot of the questions and the issues that Russell had raised.
Well, address is a big statement. Let's put it this way. The concept or the ambition of this platform is exactly that. This is why we don't use primary care center, we use community life center. Because if you don't embed the facility in the community, you don't create trust, you don't include the community to provide services to the visitor, to the patients, it will fail. And again, the community-led center is the platform where we deliver care, because of course people need care if they are sick, but with the involvement also of NGOs and local entrepreneurs, you can also start to look to the other side of the coin, to create a more healthy lifestyle, to create entrepreneurial activity that can deliver food, transportation, maintenance to the service itself. So it's a complex ecosystem that has the ambition to go beyond the delivery of pure diagnosis or treatment. We want really to embed the center in the community to create more healthier community. Of course, it's complex. This is why I said it's a problem of systemic nature. But this is why we need to create an ecosystem of partners where we need the government, we need NGOs on the ground, development organization, new funding model, new business model. And I think for me, it's the most difficult, complicated part to put in place. But if you put in place, you can create healthier community, and the cost also of treatment can decrease.
Zameer, let me bring you into the conversation now. The site visit we are going to go to later this afternoon is a true example, really, of a public-private partnership, right? The CTICC probably has one of the busiest vaccination centers in Cape Town. When I went there, it literally took me 23 minutes from point of entering the door to leaving, and that includes the 15 minutes of having to wait while well, I'm monitoring myself, I suppose, as to the impact of the vaccine. Who should be brought to the table when it comes to designing systems? And I imagine the private sector, the NGO space, community healthcare workers, all of that ecosystem needs to be sitting with the Minister of Healthcare and saying, Minister, this is what we think will contribute towards a more inclusive and, quite frankly, just healthcare system.
Yeah, absolutely, Africa. And I think that, what COVID has taught us is that space is opening up. And so the willingness of, policymakers, decision makers in the healthcare system to listen to the voices of communities, to those outside of the kind of formal healthcare system, has definitely increased over the last 18 months. And I think the realization that, healthcare delivery and the wellness of the population at large is not just the responsibility of the Department of Health. And so I think when we think about what good solutions look like, and if one just takes very basic principles of design into account, it will tell us, let's design solutions that are firstly informed by the user, secondly informed by the user, but thirdly take into account preferences of those users in a way that enables the service to be successful. And so while, I love the fact that you're going out to the Athlone Stadium site and the CTICC and tell anyone that wants to see a good functioning site to go and see those. I think we also need to ask ourselves, is that where the population need is the highest, right? And so what would have been perfect is if the ICC was surrounded by a transport hub, so that access was made easier. Right now, probably in the Cape area, there are a couple of other areas where we could place a high volume site like that. But having said that, given that the ICC was a great location and I think has probably got among the best efficiency in the country, Africa, the question is like, how do we get people there? And so one of the design principles that should come into that discussion is around access. And making sure that it doesn't become a site that's underutilized, because we then will run into the challenge of saying, look, we've now innovated out of our skin. We've taken the service outside the healthcare system, but look, it's not being used. Are we being irresponsible with using limited resources? And I would argue, no, I think that innovation's necessary, but let's couple it with some thinking through what does the user journey look like? how is the user easily going to access this in a way that responds to their needs and preferences? Similar, to the fact that really interesting to us to see Saturday vaccination sites being pretty well utilized. Should we have actually done this to start with? Another simple thing, Africa, is 12 million South Africans queue for a social grant every month, every 30 days. Should we have run the vaccination program in SASSA queues? Who do we have gotten coverage much quicker? It's not as easy because it's taken us out of our existing kind of frame. And huge congratulations to both the national and provincial departments who have now, every single province has embraced this concept and have set up hundreds of sites in SASSA queues to meet people where they are. And I think if you take Russell's point to listen to those communities and individuals, you will hear very clearly that's a convenient spot for me to be vaccinated. 78% of people standing in those queues said exactly that to us. My preference to be vaccinated is in this queue. This is where I can afford to come once a month when I leave my home and do my shopping, is when I come for my grant queue. So, I think we should listen to the people. They'll give us the solutions.
Thank you very much, Zameer. The final question goes to you, Michelle. The person unfortunately doesn't sign the question off, but said, can we ask Michelle, on a scale of 1 to 10, how agile the innovation has become pre and during COVID, and how do we maintain this level of innovation agility?
Okay, that's a tricky one. It's pretty objective. I would say where we started was probably about a 6, and I think we between an 8 and a 9 now. If not beyond that, maybe I'm being a bit conservative here. If I look at the scale at which developments have happened, and they are all based on existing technology and expertise. We didn't bring in expertise to come and develop diagnostics here or to research, do large-scale genomic sequencing of the viruses to look for variants. It was here. So, I think we're very close now to a system that is geared for ongoing innovation, rapidly pivoting to other areas, to other needs. I hope that answers the question.
It certainly does, and I think it's a wonderful note, in fact, to bring this formal part of presentations to. Thank you very much to Dr. Michelle Mulder from the South African Medical Research Council, to Russell Rensburg from the Rural Health Advocacy Project, Dr. Simona Rocchi from Philips Experience Design, to Dr. Zameer Brey with the Bill and Melinda Gates Foundation, and to Gaurang Tanna, who's the Head of Policy Coordination and Integrated Planning at the National Department of Health. Thank you very much to each and every one of our speakers for your contributions today. I think you've given us much to think about regarding how we can, address some of the present and future challenges in the healthcare space. And we hope that come this afternoon, we're going to start seeing those incredible ideas that will help us get that closer to that solution. Joining me on the couch now is Erica Alk, who's the Group CEO of the Craft and Design Institute, as well as Sebastiaan Messerschmidt, who's the Consul General of the Consulate of the Kingdom of Netherlands. Absolutely fascinating conversations, as always. On the one hand, very sobering thoughts in terms of the state of healthcare in this country and the challenges that we need to face. But on the other hand, some fantastic news on innovation and research and development that is currently happening. Erica? I know there's no question there, but it's an invitation for you to reflect on the day's proceedings.
So yes, I think absolutely. I think our sort of bipolar South Africanness coming to the fore. I think thanks to Russell really for grounding us in some serious reality about the challenges we face and how poverty impacts on our health as a nation. But also, very, very interesting and affirming signs that actually we have the innovation, we have the capacity, we have the means to actually meet some of these challenges. So I think what sort of struck me as my sort of main takeaway is how powerful we can be when we act together, when we have a common problem or a common challenge that we all agree on and that we can act together on. I think that's what COVID has taught us. And it's almost like the question sort of going forward is, what is that common problem that we can focus ourselves on? And I mean, I think it obviously is poverty and unemployment and inequality. And how do we gather all of our forces to make sure we can tackle that?
I wonder, Sebastiaan, in our conversation yesterday, one of the issues that came out is that government is now starting to prioritize, right? Yeah. And that often with prioritizing, you can focus the resources and the attention. And if you focus on the right thing, the ripple effect obviously will be exponential, really. If you could take anything away from this morning, what priority do you think we have?
Sure, I'm glad I'm not in the government seat. It's not an easy one.
Yeah.
And Russell brought us back to the ground, and focused on where the disparity, how it goes in every single issue that we're touching upon this week. So this is a very hard question, which I definitely am not capable to answer satisfactorily at all. But what I do take from today, though, every single speaker pointed out some of the incredible challenges, but every single speaker had silver linings. Like, never waste a good crisis kind of talk. Yes, we only spend 1.5% of our GDP on research, yet we're at an 8 or level 8 or 9 in the scale of 1 to 10 of how innovative we are at the moment, which is great. Yes, our health system in South Africa doesn't get enough budget, enough attention, is maybe not agile enough, yet there is, COVID has brought different departments together, and now they're working together, also with the private sector, to make things happen. These are new developments which are so essential for our future. Yes, the Ebola crisis didn't get the attention it should have gotten because the urgency internationally wasn't as great, yet it did feed into the COVID pandemic fight. Like, how do we tackle this problem? And I agree. I mean, I had the same conversation last night with some of the guests that okay, now we've done this for COVID, what about HIV? What about tuberculosis? What about all these other, what about just flu? I mean, 11,000 people before the pandemic, I don't know how it is now, but 11,000 people per year were dying of flu just in the Western Cape. So these are big issues that also were touched on today. And what I really liked also is, and I heard that almost from all speakers, and I think Zameer was the most pertinent one in stressing that, we need to listen. We need to listen to the end user, to the people that are actually having to receive that care and have the right to receive that care as the Constitution says. And the answers are there. So you need to build that design framework, that design thinking framework, where you involve the people that it's about, every single angle. And that's why this week is the timing's perfect, and having institutes like the Craft and Design Institute is the perfect way to go about, because you need that thinking. How do you model your governance for the future? Not just by the government, but also by ourselves, by our communities, by excellent big giant companies like Philips, like indeed we used to know only from televisions, and they're very big in medical system, and they do high-tech, highbrow stuff, but they also do community centers, which is to me such a wonderful revelation. Like everybody's digging into the problem as close to where it is laying, and that's what we need to do for the future. And that's really a big silver lining of this COVID crisis, that we are getting a better understanding of how do we get the solutions as close to the problem as it is, and not just by sitting behind a desk or in a company or as a policymaker or all of those. And of course, the big question then, which came up repeatedly today, is that how do we harness that, and how do we make sure that going forward we take advantage of that collaboration, of that sharing of data and information and skill, of all of that, to address then things that are not as emergency in their urgency as COVID-19 seems to be. What are we going to be doing this afternoon?
So from now, we're going to visit the Athlone drive-through vaccination centre. So I hope people are going to be joining us physically and online. And then this afternoon again, we have from 3 to 5 our design thinking ideation workshop. So anybody with ideas that have been stimulated, and I think there are many through this morning's discussion, or people who are working on innovation currently, to join the ideation session. We had a great session yesterday, and it's really an opportunity to grapple with the problem and potential solutions.
And of course, for both those, you can either join us physically or you can join us virtually, and the link for the virtual joinings will be shared on this platform now, because we don't have it in front of us. Thank you very much, Erica, and thank you, Sebastiaan. Thank you to all of you for coming through here today. I hope you were inspired by the conversations. We'll be back here tomorrow morning at 10 o'clock for a conversation on food and food security, which obviously is a huge area of focus. And remember, on Thursday, we'll be tackling the mammoth topic of water and sanitation. Have a wonderful Tuesday.